Welcome to our afternoon session, very aptly entitled, If You've Seen One DPC Practice, You've Seen One DPC Practice. I want to echo folks who've been up here before in thanking the Academy, our other host, Bethany, and everyone else who's worked hard to put this summit together. And thank all of you for being here. My name is Tom White. I am a direct primary care family physician in North Carolina, small town of Cherryville, and it's very much a privilege to serve as the moderator for this panel this afternoon. I opened my practice in March of 2015, in large part due to this DPC summit and to a number of you who are in this room today, and you know who you are, and I thank you from the bottom of my heart. Before we get started with the panel, I'm going to take about 30 seconds privilege here to recognize a couple of people special. I took this, I wouldn't even call it a plunge. In hindsight, it seemed so logical and obvious what I did to choose direct primary care. But when I did this in 2015, someone took the jump with me. He's here today. I just want to thank him in front of all of you. It's Dr. David Lane sitting at the front. Thank you, David. And then this past August, I had the incredible honor and experience of a young resident right out of training, right out of residency, choose direct primary care and choose to partner with me. And he's here today, Dr. Josh Carpenter. I'd like for him to stand, please. Josh will be a leader in direct primary care for years to come. He calls me the old goat who likes to wear pink, and I call him the young stallion who wears khakis. So thank you, both of you, for what you've done and for being here. So on the panel today, we have three very impressive direct primary care physicians, and they represent three very unique and very successful practices. Before I ask them to introduce themselves, I want to address this issue of direct primary care and the individuality that we all recognize and the diversity of direct primary care, because I want to bring us back to something. I think we heard it very, very well from Jeff this morning, and that is that, it is true that we are like snowflakes, being very individual, and you've seen one practice, you've seen one practice. That's partially true. If you read that JAMA article tonight, as I did, coming in on the plane last night, some people think we're flakes, not just snowflakes. I do encourage everyone to read that and respond to it. We have so much in common in direct primary care. And those of you who are contemplating direct primary care, I really want you to leave this weekend, and I'm sure you will, with this appreciation of the common bond that those of us who have chosen this have with each other. I've never in my entire career in medicine experienced the camaraderie, the collegiality, the support for one another, and it's amazing. So despite us all having our very unique differences in regions of the country and demographics and practice styles and types that you'll hear about today, we have so much in common and so much good in common. Snowflakes are unique. We're unique, but we're very resilient. We don't melt. We're tough, right, Julie? We're really tough. We're resilient. We know our mission and our principles, and we're here to stay. And through all seasons and despite all the doubters to whom we can very politely say, be well. So enough said to introduce our panel this afternoon. You've heard their names. I'm going to let them introduce themselves, where they're from, a little bit about their practice, and then something that makes your direct primary care practice unique. So we'll go across the panel here. Dr. Corey Annis from North Carolina. Go ahead, Corey.
This is already on. Okay, hi. I'm Corey Annis. My company's name is Unorthodox, and you'll see in the program that there's a little trademark after it. It's not because it's a chain. It's because when I came up with such a cool name, 2 doctors tried to steal it from me, so I had to go out and trademark it. My practice is in Carrboro, North Carolina, which is the back door of UNC, right on the border with Chapel Hill, but I got my med-peds, internal medicine and pediatrics residency. I completed that at the other school, Duke, in 1996. I tell people that I practice medicine cradle to grave as long as you're not pregnant. I have practiced medicine for 35 plus years, and those of you math geeks out there are saying, well, she just came out in 96. I actually was a physician's assistant for 10 years prior to going back to medical school, and it gave me 2 gifts. One was a lot more hands-on medicine than I actually got in my residency program, and the second was a big education in relationship building. When physician's assistants first came on the scene in the early 1980s, our job was to fill in the bad social skills that our employing physicians weren't supposed to have. So I spent a lot of time making a lot of relationships with a lot of people, and then it turned out that I went back to medical school for exactly the same reason I became a DPC doctor. I discovered that I hated having other people interfere with relationships I had worked so hard to build. So I went back and I became an MD, and from 1996 on, I have been self-employed, or at least I called it self-employed, and one day I woke up and realized I was actually working for the government and the insurance industry, and most frighteningly, Big Pharma. And that, about 2010 was when my awakening came. And I think this was probably before direct primary care even had a name, but I was having a conversation with an entrepreneur patient of mine who travels the globe doing all kinds of internet security wonky stuff, and he had been missing a lot of appointments, and I wanted him to be on a 3-month schedule, and I said, I'm going to see you in 3 months, and he said, I'm going to be in Singapore, can I Skype you? And I said, no, and he said, why not? And I thought about it for a minute, and then I said, well, because your insurance company won't pay me, and he said, but I will. And those 3 words pretty much changed the trajectory of my career from that moment on, because it had never occurred to me that what I did would have value enough that somebody would open their wallet and hand it to me. Now, that's a generational thing, but that it didn't occur to me that people would be willing to value me in such a direct way. It had been long since anyone had actually done that. And he said, I said, why would you do that? And he said, because when I get up from my desk and make the half-a-day trip to come to your office, sit in your office, see you, go home, go to the pharmacy, blah, 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 I'm losing money. I work for myself. And he said, when I have 30 minutes of your undivided attention, I get better, safer, more coordinated, and more affordable care, i.e. DPC. He sat there and evaluated or gave to me the value that I gave to him and what he saw about me, and it was something that I had long since stopped knowing because of I was being fed my value by the industry. One of the things that's unique about this practice, the most unique thing, is the name itself, Unorthodox, which I trademarked because A, it's cool, and B, it's easy to steal. But I'm a really ordinary Western allopathic MD. I don't wave crystals, I don't jump around in the moonlight, I don't evoke strange powers. What is unorthodox is that I've been restored. I now understand the value, the real value to my patients of my time, my attention, my training, and my care. It's not now my company name any longer, it is my resume. And it's become the resume and the identity of the patients who support my practice. And I'm really happy to be here to talk to you.
I'm Maura McLaughlin. My practice is Blue Ridge Family Practice. I'm located in Crozet, Virginia, which is a small community just outside Charlottesville. I prior to opening my direct primary care practice, I worked for 9 years as an academic physician at a small rural practice and loved it for most of the time. Towards the end of my time there, our organization had become part of an accountable care organization. We'd become part of a patient-centered, supposedly patient-centered medical home. And I found, from early on in my training when my job was to go in the room and sit down and look at the patient and ask what brought them in and take care of them, that had somehow morphed into me standing up and clicking boxes on a computer screen and, having the nurse room the patient for 20 minutes and me have -5 minutes to see the patient. So all of that sort of led to a lot of frustration, and I tried as hard as I could to sort of change things within the system. I was frankly ready to just quit medicine and go teach school until my husband reminded me I wasn't really qualified with a certificate to do that either. And so fortunately, I happened to be at a Virginia Academy of Family Practice meeting where someone, Dr. Forrest, who spoke earlier, was giving a talk on direct primary care. And I had never heard of it. I had heard of concierge. I wasn't really interested in just caring for the wealthy. So sat there and listened to the talk, and at the end of it, it was the only time I, after a medical talk, wanted to just stand up and cheer, because I felt like this solves every problem from what I'm experiencing as a physician, what my patients are telling me they're experiencing, and it also solves things from the system perspective. So less than a year after that, I've opened my own practice, January of 2016, so it's now been about 2.5 years. One thing that makes my practice maybe different is I am a solo practice with no staff. So I'm the physician there, I draw the blood, I answer the phone. So it's a smaller micro practice, and I think that's a great way to go, at least a great way to start out, and I've been really happy doing it that way.
Thank you.
Hi, I'm Kylie Vanneman. I am co-founder of a practice called Health Suite 110 in Overland Park, Kansas. I went to medical school and residency at the University of Missouri in Columbia, and after that, planned to move back home to Kansas City and start work, but in the meantime, decided to take a leap and went to New Zealand for 6 months to do locum tenens, because we figured once we moved home, we probably wouldn't be leaving to go that far away again. So my husband and my 18-month-old son and I went for 6 months and ended up staying for 3.5 years. It was wonderful. People ask why we came back, but family is ultimately the main thing. So we moved back for lots of family reasons, and are glad we did. Once I moved back, though, I joined a hospital-owned primary care practice. And thought that was going to be my forever job. It was the first time I had a fancy office, and I had, dozens of staff people and, wood-paneled walls, and I couldn't be more miserable. So I was probably happy the first 6 months until they really started to kind of push the numbers, and I realized that that was not going to be a sustainable practice for me. So I didn't know quite what I was going to do, but when you're, it's the age of the internet, so you start Googling ideas, and somewhere along the line I ran into information about Atlas MD in Wichita, and called and talked to Dr. Josh, like many people have done. And what he talked about reminded me a lot of an article I'd read back in medical school called the Robin Hood Practice. I don't know if anyone's familiar with that. It's a Catholic non-for-profit practice in California, I believe. And the model of that practice was half of the patients were what were known as benefactors, so they paid a yearly membership fee, and then the other half were recipients, and they got free care. So it was a really cool model, and I thought that sounded like something that I wanted to do. And then after kind of finishing up my job, I was lucky enough to meet a like-minded colleague, Dr. Hasib Ahmed, who's an internal medicine doctor who was going through the same kind of career crisis as I was, who was actually introduced, we were introduced through his wife, who was actually a patient of mine at my hospital and clinic. And one day she said, "You should really meet my husband. You guys say all the same things." So finally we did, after about 4 or 5 months, met for coffee, really hit it off, and the rest is history.
Excellent. Very good. Thank you. So Jeff Gold said earlier this morning that direct primary care it's not particularly easy. It's hard. My colleague and friend Amy Walsh and I say this to each other many times and very often. This is not easy. This is not easier. It's a lot better. So my question for the panel is, we have a number of, I'm sure, residents and other folks in the audience, and one of the concerns of medical students and residents today, and should be the concern of all of us, is this idea of work-life balance. So I would like for the panel to address this. How do you manage family and work? How do you manage that? Do patients call you all night long, every weekend? How many texts have you gotten since you've been up here on the stage? So let's begin with Dr. McLaughlin. How do you manage this? And you have a micro practice, so how do you do this by yourself?
Yeah, I think that's one of the things that feels the scariest for physicians when they're thinking about it. Certainly that's a question I get a lot about, like all the phone calls. So just answer that part first. In the 2.5 years that I have been open, and I have a small practice, I have about 200 patients because it's just me. In the 2.5 years that I've been open, I have been woken up at night exactly twice. And really, because patients know, and I think any other DPC doctor will tell you the same thing, because patients know they can access us during the day, they really try to keep it to business hours. And often I can see, like, right on the dot at 8 a.m., someone will call, and I can tell they've been sitting there waiting until an appropriate time to call. And the other thing is they know that it's me answering, and I think that makes all the difference. If you think about in residency, when we were covering for tens of thousands of patients, and the patients just sort of assume that there's someone just waiting and eager at 3 a.m. to talk about their lab results or whatever. So it's just a totally different experience. And then in sort of general work-life balance, so I have 2 young children who are in elementary school. My husband is also a physician. So work-life balance is something I thought a lot about. We had our 2 children right after I graduated residency. So those early years of busy practice life were also really busy with young children. And I spent lots of time in my previous job sort of calculating the amount of minutes and hours I was spending with my children versus how much time they were at the daycare, and was it equal and was it all balanced? And what I finally now have realized, now that I'm at this point in my life, is I'm no longer trying to sort of balance like work on this side and the rest of my life over here and trying to make it somehow equal. It's just more of a work-life mix, and I feel good about the mix. And so sort of specific things, my husband has been incredibly supportive, and I think that's really important for anyone if you're making this decision and you have a spouse or significant other. I think it's really important that they sort of understand, and they may lag a little bit behind you in their understanding of like how important this is and that this is the right thing to do, but it's really important to have that support. I didn't choose to move into DPC because of the flexibility, but that has been one of the most delightful things about it. So my practice is about 7 minutes from our house. Our kids are right down the street at their elementary school. So it's just really, everything is really easy, and it's all kind of integrated together.
Very good. Mart, if patients have your cell phone to use an answering service,
So
how do you manage this?
I use an answering service called Answer Advantage, which for anyone who's thinking of doing this solo, I would highly recommend. And so the way it works, patients call. It's my cell phone, which I'm not sure I'd recommend using my cell phone. I just did it because I was doing this kind of quickly and I was cheap, so I didn't want to pay for another phone. So patients call. It's my regular cell phone number. They have an option to press 1, which they leave a message that's urgent that will call through to me. If they press 2, it leaves just a message that doesn't even ring through. I have my phone set on Do Not Disturb, so all that rings through are the urgent messages or my family or anybody that I've set in that select group. So that works really well. It's very rare. Probably maybe once a week someone will actually leave an urgent message for me. Because again, I try to respond to them, at lunch, I'll check them just whenever I have time, but I'm not getting constantly bothered or constantly worried about the phone ringing.
Excellent. Kylie?
So I would agree about the nighttime phone calls. So we've been in practice for about 3 years now, and I've probably been woken up about half a dozen times. And I have a panel of 500 now, and it's the same reason. People know they can get you, and they know it's going to be you. So if someone calls you at 2 in the morning, they better have a really good reason. And then the other side of it, so as far as work-life balance, so I have 2 young children as well. I have an 11-year-old son, and then 7 months after opening, I had a daughter. So I have a 2.5-year-old. And luckily, I practice with another physician, my co-founder, and a third doc that joined us last August. At the time, it was just my partner, and he was just amazing. So I took 6 weeks off. The lovely thing about being a DPC doc is the other awesome DPC docs in your community. And so I just asked them as friends, like, hey, I just had a baby. Do you mind, covering my calls, or if someone needs stitches, or if a kid needs to be seen, is it okay if you see them? And I had so much support. I think maybe I sent 1 or 2 kids during that whole time. But that was such a blessing. And then I worked kind of half-time for another 6 weeks. So I got 12-ish weeks of maternity time off. And my husband actually stays at home. He's an architect. He works from home, but his primary job has been to raise our kids. We had our first in residency, so that was how it worked out for us, which has been great.
Excellent. Corey?
Well, I don't have kids. I spend half my day as a pediatrician, so I help other people raise theirs. And I've got to say, I made my baby my first practice, which was the insurance-based practice, and an orthodoc has been my second baby. And I probably work as hard as I ever did, but my work now is rejuvenating instead of eating pieces out of me. And so I find that I don't resent the work, and I find that my husband doesn't resent the work either, because I don't bitch as much as I used to. And, I'm much more likely to show up when I say I'm going to show up, and it's been easier for me to take time off, because in my old model, it was basically an eat what you shoot model. So if I wasn't there working, I wasn't drawing a paycheck. And with a membership model, I can go away for a little while and not worry about a dip in my income, which really helps. The 24-hour access thing it's really interesting. I have always had 24-hour access by phone, pager. This is the first time I've actually broadened it to text access and all other any other way you can digitally access people. But I've found exactly the same thing to be true now that was true when I started in practice. When I have a relationship with people, when people know who's going to answer the phone, they are unbelievably respectful about how they use it. They, I've been open, an orthodoc has been open for 3 years this past July 1st, and I have been awakened in the middle of the night by one of my patients once. And it's astonishing to me. Now, I get paged, or not paged, I get texted an awful lot, but I set the rules from the beginning. If you're going to text me, this is not an urgent way to get me. This is how you can leave questions, and I'll get back to them. I'll get back to you when I can. And everybody loves that. They just want to know that whatever their concern is, they're going to be heard. And then I have an old-fashioned radio wave pager to get to me when all other digital systems fail. And it never goes off. So I just think that relationship medicine extends way further than our relationship with our patients. It extends to their relationship with us and their respect for us.
I just want to add real quick to that too. The other nice thing about it, the respect with the patients, it really does go both ways, which is nice. I usually try to send out an email if I'm going to be gone on vacation, or for this conference I'll be gone today. So I have a little automatic email that says I'm gone today. Contact the clinic or whatever they need to do. And usually I get another little email right afterwards saying, "Oh, great! Have a great time. Enjoy your family. Enjoy the conference," which is just so nice, because we've always been such what it feels like an intimate part of people's lives, and now they're sort of getting to be that for us, and it's very rewarding.
Very good. So those of you who are in a direct primary care practice have had this experience many times. Someone asks you, "What do you do?" And you begin to tell them, and they say, "Oh, you have one of those concierge practices, don't you?" So I think we all have our elevator speech where we try to very quickly distinguish what we do from concierge. But one of the concerns and one of the sentiments expressed frequently is, well, what about the folks that are less well-to-do? Dr. Farce mentioned 40% of his patients are uninsured. So I want the panel to address this issue We'll begin with Kylie. How do you address this issue of folks maybe of somewhat lesser means in your particular practice?
Yeah, so this has always been a really important topic for me and my partners. In residency, I worked for a federally qualified health center. I've done some work abroad and on Indian health reservations and all of that. And so I've always felt that medicine is a calling for me and should be accessible to everyone. And we never wanted to be elitist or restrictive in our practice. So we've tried to price ourselves what we feel is reasonable, but we do a variety of things. Pretty much if someone's having trouble paying and they stay in touch with us and tell us what's going on, we will never fire them. So we actually just finally kind of instituted a more formal kind of policy, I guess you'd call it. But if anyone's kind of struggling financially, they're in between jobs or they're whatever it is, we give them the opportunity to apply for our scholarship program. And they just have to fill out a simple piece of paper that says, how long they've been a member, what they're currently paying, just briefly what their circumstances are at the moment. If they can pay something each month, how much would be affordable to them, and then how long they need the assistance. And then the last question we ask is, when finances would allow, would you be willing to help pay for another member's membership if they were in a similar situation? And so that's worked really well. It helps us kind of keep track of things. Sometimes we assume because someone's lost their job or they've whatever that they can't pay anything, but usually they're very happy to pay something. And so we just leave it to them to say what's affordable to them, and then it gives us a timeline on is this a 1 month thing, is this a 6 month thing, and it doesn't have us assuming anything, which is nice. And so we give a lot of free care. In my old practice, people who couldn't pay, they couldn't even get in the door. I didn't even get to make that decision about whether or not I saw them. I would have loved to have seen them, but that was not my choice to make. And so this is nice to be able to have that as an option again for us.
Good. Corey, would you like to address that?
Yes. One day I was speaking about this in a conference in Houston, and someone stood up at the back of the room and basically hammered me about access to care. And wasn't I doing something elitist? And I said, for $49 a month, it's hard to call me elitist, but and 30 bucks, 29 if you're a kid. But I said, I used the moment to say something about the difference between health insurance and access. I said, we've created an incredibly expensive system by giving a lot of people insurance and nowhere to use it but the emergency room. It's like access to insurance and access to care are not the same things. I said, imagine what would happen if, say, in the government, if they wanted to be involved in this in a meaningful way, they actually pumped out made it easy for people to become primary care physicians and then gave people a cell phone and something equivalent to medical food stamps and let them make a choice about where they want to go see their doctors. There's all kinds of different ways to do this, but the thing about DPC for me has been that the answers to these questions are so much more intriguing and so much more innovative when we're all allowed to just do it and not be told how to do it. I'm really proud of the fact that I have patients from every possible socioeconomic strata, every possible wing of the political spectrum, every race, creed, color, religion, all coming to my practice, whether they come on the bus or by foot or in a Mercedes, and I don't have to be a different kind of doctor based on who is paying their bill. They're paying their bill, and I get to go in the exam room, shut the door, and be the same doctor to every single body, and that is the way DPC's leveled the playing field for me as a physician and for my patients.
Very good. Maura?
I love this question because I get it all the time. We live in a small community, and I have a lot of neighbors or friends of friends who are like, "Oh, I hear you're doing concierge now," and I respond in a way where I want to strangle them because that's not what I'm doing. And my husband was like, after a few of these encounters, he's like, "They're really not trying to insult you. Like other people don't necessarily have that same connotation." But I was very definite when I started my direct primary care practice that I wanted to be, like Corey mentioned, open to people of all economic levels. I wanted to take care of the young to the old, and I very deliberately tried to price my practice to make it accessible to everyone. And as I got into doing the practice, I started to realize that direct primary care really offers something that no other system of care does, and that is for people with high deductible plans, which I just looked up for 2017, 43% of Americans have a high deductible plan. So this is a plan where people are paying $1,300 or more out of pocket before the insurance kicks in. And so for those people, there is nowhere else in the system that they can access reasonable health care. And so we are really offering, for that 43% of the population, we offer a way for them to get excellent medical care that they just would not have access to otherwise. Because otherwise they're paying those, artificially insurance inflated rates for the visits, for the medications, for the labs. So I really see that as a service that I'm providing to the community. And then in many areas of the country, Charlottesville, where we live, had the highest insurance premiums in the country for people who are buying it on the ACA market. So for a family of 4, it's $36,000 for premiums alone, and that's with like a $7,500 deductible. So I have lots and lots of patients who, are independent, they have a small business or they work for a small business and they just weren't able to afford it, just wasn't in their budget with everything else with their families. So I have a lot of people who are very grateful to be able to access medical care at a reasonable cost.
Very good. Holly? You've already... So what about Medicaid and Medicare? That's been mentioned a couple times. We had this morning, and previous lecture was about Medicare. Do you have patients with Medicaid? Do you have patients with Medicare? Can you share that with the audience?
I have both, and I was actually shocked at how many people with Medicare. I thought I would maybe have a handful of very wealthy patients. I have probably about 20%, maybe slightly higher, of my population is Medicare, and I see a lot of young families, so I could definitely sort of, as I add people in, have a higher percentage of Medicare. And for patients on Medicare, I mean, these are patients who often will come in, I'm sure you all see them in your clinics, they come in with a med list with 15 or 20 medications, they have medications and they have side effects, so they have more medications added. And so they really recognize the value of someone who can sit down with them for an hour for that first visit and, and sort through and get rid of some of the medicines and really take the time to really care for them. And then I also do have patients on Medicaid, and I have patients whose parents or grandparents are actually paying me for their care because they recognize, even though they have Medicaid, and there's a fair number of providers in our area who take Medicaid, but often these patients have social issues that are causing them to get lost in the system, and the family members recognize that, so they'll pay me because they know, and the patients love it. They can call me or text me, and I know who they are, and they know who I am, and one of my patients said to me, it feels so good, I have a person, and it's great that I'm glad to be the person. So I think DPC, as it is now, is also a great resource for Medicare, Medicaid patients.
Kylie?
I don't have a lot to add. I mean, we do too. We have Medicaid, Medicare, uninsured, high deductible, all the whole gamut. Even some people that have health employer-based plans, whatever. It's kind of a question. We get that question all the time, and we're like, oh, I guess we kind of ask that. I mean, we try to keep track in their chart in case they need to go see someone so we can help with a referral. But we don't use it, so we don't really care what they have. So it's always the tricky question though when someone calls on the phone and says, "Do you accept?" And we hate to say no because that's not maybe what they're actually needing to know. So we try to work on that. But the other thing I was going to say that's nice that we didn't really touch on yet, and I don't know who all does house calls and things. Our practice does house calls, and that's such a nice part of our practice as well that I wasn't able to do in a traditional practice that I love to do now, because you learn so much about people when you actually get to go into their homes and see how they live and see all their medicine bottles that from years past that are just sitting there. Who knows what they're doing. And I feel like the people that I've gotten to do home visits on, that just instantly bonds us in ways that you just can't get through an office visit.
On the house call issue, I can remember 4 years ago I was talking to someone, getting advice, not someone in this room, and issue of house calls came up, and they said, well, Tom, how much are you going to charge for house calls? And I said, well, I don't know. I'm not sure I'm going to charge anything extra. And they said, oh, Tom, you must charge 150, 200, 250 per house call. And I said, well, we'll see how it goes. Patients almost never demand the house call. It's usually my idea. It's often my idea driving home from work or after church. So how would I charge someone if it's my idea to drop by their house? Anyway, it works. In fact, folks are so respectful that you're willing to do that. So thanks for bringing up the house call issue. Corey, you want to, about Medicaid, you know, a lot of children in North Carolina are covered by Medicaid, right?
Yes.
So how about Medicaid and Medicare in your practice?
Well, the interesting thing about that is I realize when people ask if I accept their insurance, I say, well, I accept you. I'm going to let you determine what your insurance is. So but I have a fair number of parents whose children are on Medicaid who are so happy to have a person that, you know, talks to them and, you know, fields their calls and gets their kids in that day, occasionally comes to the house. That, you know, the extra that they pay for their membership, they're ecstatic about that. And, you know, so I don't know how much more I can say about that. I don't have any specific problem with the government healthcare, government paying for healthcare. They just do it inefficiently and ham-handedly. You know, ostensibly they're all supposed to be on our side. But it's really not about whether or not I deal with the government. It's about how I deal with the patients, and are they happy to pay the extra to see me, to make them safer and healthier and cheaper. In the end, I save them money, even on Medicaid.
Keep the microphone. Okay. We already have one question that's percolating up about caring for children, and as someone trained in pediatrics, and would like to hear, how do you handle children in your practice? How do you handle vaccines? Because there's some differences between the children and adults.
Yeah, there's, how many, is there anybody in here who's a straight up pediatrician or med peds doc? Oh, crickets. Hey. I'm really hoping to change that. And vaccines are probably the number one reason that I've gotten. I have, you know, the practice that I left, or that I'm, you know, now peripherally related to, had 4 other med peds docs in it. And the big issue was, we can't do this because we can't cover vaccines. And so it's turned out to be to my benefit. I have a somewhat special situation, but I'm going to cover more. Because I own the building, so I wasn't going anywhere. I carved out 350 square feet in the corner of the building, and that's where Unorthodox sits. But my practice sits right next door. So essentially what I'm doing for their vaccinations, if they have insurance that covers it, is writing them a prescription to go next door, which is literally out the back door of my practice and into the hallway of the other practice, and get their vaccinations done. Because they have the room for the big-ass vaccine freezer. I don't. 350 square feet, it's like practicing in a recreational vehicle. So that's, you know, if they have insurance, that's where they go. If they don't have insurance, North Carolina has a state vaccination program, and all they have to do, including all my patients who have health sharing ministries, cost sharing ministries, they don't have insurance, so technically they qualify for a state vaccine. So I basically do the same thing. Now, if I didn't have that as a resource for myself, I've talked to lots of other pediatricians in North Carolina who are starting to do this, the brave and the bold, who are ordering vaccines one at a time. I do have a backup relationship with a local pharmacist who can bring in vaccinations, you know, by the truckload, and sell them to me one by one if that's what I needed to do. If the practice next door folded tomorrow, I would still have that access. Most people in my practice don't want to go sit at the health department. You know, many of them are willing to, they would pay me outright for their vaccines if there wasn't any other way to do it, because they don't want to go sit. They don't want to go to a cattle call anywhere, whether that's at Duke University or the health department. So they would pay me to come and get their kids' vaccines done there. Many will get their vaccines done and they'll submit for reimbursement to their own insurance plan. because almost everyone who has insurance has at least at the moment, has their preventive vaccines covered. One of the things that has been really valuable for me is that I don't throw patients out of my office if they want to do an alternative vaccine schedule, despite what the American Academy of Pediatrics says. Now, I don't want my patients necessarily to know this, but I have succeeded in pretty much getting everyone who ever enters my practice appropriately vaccinated, even if it's taken years to do it, because I don't turn them away. I don't tell them they're crazy for being suspicious of the motives of my profession and the industry that backs me. I don't toss them out, but we work carefully to create a trusting relationship that ultimately gets their kids vaccinated. And my being able to say, but the fact that the word on the street is Dr. Annis isn't going to throw you out for not having for following a Sears vaccine schedule or whatever, she's not going to throw you out, brings me a tremendous amount of business. And a tremendous amount of trust. And, it is still my mission to get those kids vaccinated, but I do it in a way that has the parents finally buying in. Let's see what else. That probably was more than enough time. But one of the things I do want to family practitioners who want to see kids, the most important thing you need to know, and this is from years of experience in med-peds in both practices, pediatrics rises and falls on your ability to do urgent response. Either get the kids into the office or respond to the parents or do a video call or do a phone call or answer their text messages same day. If you do not curate the adult end of your practice, sooner or later the adults in your practice will push the kids out. And I have asked multiple family practitioners who've been in practice for a long time who've had exactly this situation happen. I limit my Medicare patients to a certain percentage of the practice, no more than 15%. My patients over 50, no more than 25%. My goal is to have 25 to 35% kids in the practice, and all the rest are young adults, the parents of those kids. But if you want to see kids, you really have to stem the flow of adults in your practice at some point. And most people are really understanding about that. But then if you're in a small town, you need to draw the line and you need to keep it. And I have way more to say about that, but
well, no, that's excellent. While we're on that, and then we'll move to the other two panelists. I know this is somewhat artificial to ask what are your office hours, but since you brought that up about urgent calls, and can you speak to your office hours, although we know that that's somewhat an artificial distinction.
Well, I'm really glad you asked that, because that was on my list of things to talk about.
Okay,
good. Because I don't want to be in my office from 7 a.m. to 7 p.m., which is the hours of many pediatric practices, right. I stagger my half days so that some mornings I open early and other mornings I close, or other afternoons I close late. I work about a half day, 5 days a week. And the parents with teenagers who want to bring them after school love the afternoon hours. The parents who need to get off to work and trying to decide whether their kid is going to stay home or go to daycare that day really like the morning hours. But everybody loves the texting program where they say, should I worry about this? Do I need to be seen? And the ability to respond to people when they need it is what pediatrics rises and falls on. It's important to everything else that you do, but if you turn an anxious mother away too many times, she's going to go to the practice that opens at 7 a.m. 7 days a week.
Very good. Mara, go ahead.
So I do not have any set office hours. The patients just sort of assume I'm in the office. Often I'm at home in my pajamas, talking to them from the kitchen table, or sitting on the couch with the kids. So I purposely don't post any office specific hours. I just switched my malpractice to part-time, which is less than 20 hours per week per my carrier. So I'm definitely seeing patients less than that. I will say with DPC, Dr. White mentioned earlier, even though, that sounds like probably super easy for those of you who are in a traditional fee-for-service practice, it is not easier, it's better though. It's less time with the patient in terms of like absolute hours, longer visit times, but there's always work that we're doing. I'm thinking about it, I'm available. So I don't think DPC is, I wouldn't want anyone to jump into it thinking this is going to be easy, but it's very flexible and you can make it however works for you and your patients.
Our office hours are a little more standard. We're 9 to 5 Monday through Thursday, and then 9 to noon on Fridays. So we have Friday afternoons off, and then I started taking Wednesday afternoons off, just because. So But that means our nurses are still there. Friday afternoons are open so we can have team meetings, or if there's a project that needs to be done, or we just wrap everything up before the weekend. So works well.
So around 11 o'clock this morning, I got a text, and then I returned the call to the mother. She had a question about one of her children who was sick, and she said, we're all going on a cruise tomorrow, so I just wanted to have your reassurance about my child's symptoms. So Dr. Carpenter, I just wanted to let you know, I told her I would go on the cruise with them just in case. What else does a good DPC doctor do? I'll see you in about a week. Royal Caribbean is the number to call. I think we have time for questions from the audience at this point. Some of these have already been addressed. So one is, what about ancillary services? And there are many. There are several that have been mentioned. Counseling services, massage therapy, medication dispensing. What about those? And we'll start with Kylie, work our way back up this way.
Yeah, so we try to do as much as we can in the office. So our membership fee covers anything we can do for you in clinic. So if you need a joint injection or an EKG, your spirometry, ear clean out, stitches, whatever, that's all included. And then we do have a dispensary. I've learned not to call it a pharmacy because we're not like open to the public, but we do dispense medicines to our patients. So we do, in the state of Kansas, we are allowed to dispense from our office. So we just order things at wholesale and then just sell them at cost. We mark them up a little to cover the cost of the labels and the bottles and the bags and stuff like that, but we're not making a profit off of that. And then we have a deal like many practices do with Quest or other local labs, where they're super cheap. And then we've developed relationships with the 2 independent imaging facilities in our town who have been amazing at giving us cash prices for our patients. And then anyone else that will talk with us, like we are, if someone needs an ENT, like that gives us the opportunity to reach out and say, look, I've got this situation. What can we do to work on that? And so once you've kind of built a relationship with a specialist for one patient, then you can continue to work with them about, okay, well, what about with this procedure and what about that? And so slowly over time, we've, managed to get most specialties some sort of relationship with them for our cash paying patients. And we do that as a region. We have the Midwest DPC Alliance, and we all work together to try to work on those relationships, and then we share that information with all the other DPC providers in our area so we don't all have to reinvent the wheel.
What about behavioral health counseling? What about a dietitian, an RD? Any special arrangements that you've made in your practice with those?
Counseling, same thing as the specialists. There's actually, and then the dietitian, we actually had a dietitian that we, that used our space. She's since gone and kind of is running another business, so she's not as available, but there's other independent dietitians that we work with. And what's really cool is there's one of the physical therapy clinics that we work with a lot. They actually rolled out the first direct PT practice in the country. And so I guess I can't say dollars, can I? But they charge a very minimal amount for unlimited PT per month. And so that's been fantastic. So we use them quite a lot.
Okay. Or what about ancillary services at your practice?
I'm glad Kylie mentioned the sort of regional alliances, because I think this is something that's very state specific, and it's really helpful to connect with other people that are practicing near you to share information, and it can be really different from one region to another. So I'm in Virginia. I think across the country, most, if not all, DPC practices have lab deals. So that's a huge cost savings for patients. I did labs on a patient of mine. It was 4 labs, $38 total. And he said with his insurance the previous year, those same exact tests had cost him $1,300. So he paid for his year of being my patient, with the lab tests alone. I do not dispense. Dispensing is a little bit challenging in Virginia, so I don't dispense medicines, but I will just typically, if it's a patient that does not have insurance or has a high deductible that's not going to cover the med, I will print out a GoodRx coupon, I'll go through it and just print it. And patients are super appreciative of that. A lot of them, even though I feel like most of us know about GoodRx, a lot of the patients have not seen it before, and so then they can just walk over to the pharmacy with that coupon in hand. And we're fortunate to have an independent pharmacy that gives really good cash pricing. They've been awesome to work with. other ancillary services. So I tried, when I was setting my practice up, I didn't intend to include a lot of those ancillary services because I really just wanted to keep it very low overhead for me and pass on that savings to make it low cost, like low barrier of entry for patients, because I was really trying to make it affordable. So I will talk with patients if they need those services, and now I have enough experience that I've priced out lots of things, I've kept track of it, so I can let patients know kind of ballpark, or I'll call if it's a specific test and help them figure out what is going to be most cost effective. There's a great resource called MD Save for radiology testing. We don't have any independent imaging centers that are close to us. It's all owned by local health systems who have been unwilling to negotiate. But MD Save, you can actually go on, choose your test, put in your zip code, and it'll give you the price, and the patient just pays online with a credit card, prints that out and brings it and pays with that, and then you just send the order to that radiology center. So that's worked great for me for the imaging component. MD Save.
All right. A lot of good questions coming up from the audience. So let's talk about marketing a little bit. What marketing strategies did you find most effective as you were growing your practice? Your practices are fairly mature, but what worked for you? What works now for your practice? Go ahead, Corey.
Facebook, and Facebook. And, you know, having street cred, I mean, having been a doctor in the area for 20 years, the word of mouth never fails, and trust me, the word of mouth about this is insane. The practice I came from had great word of mouth, but the practice that I've now started is essentially the practice that we had at the very beginning before insurance wrapped its tentacles into us. The idea for unorthodox is 20 years old, you know, just take good care of people. But the Facebook was very helpful, and making sure that patients who are connected with groups where I want to be seen, like the Chapel Hill Mothers Club or whatever, is, you know, asking my patients if they say something really nice about me, I say, well, you know, would you be interested in saying that same thing on your mother's group or your what are they called? Neighborhood. Yeah, I'm on one and I can't think of it right now. But getting into the social places has been way more valuable than any kind of print advertising or anything else I've ever done. I wish I had every penny back that I'd ever spent on any of that, because what one person says about me, a satisfied patient is worth its weight in gold.
Mara.
I would agree with that. I personally hate Facebook, but I've forced myself, and if you look at my account, you'll see I rarely post now. My practice is full, so I've kind of dropped the ball on that a little. But I think by far it's the biggest bang for your buck. If you don't know this, you can boost a post for like $10 to $30. You can choose who you want it to go to, like geographically or interests, and it'll go out to thousands of people. And with last year, when all the insurance market was haywire in our area, there was tons of buzz about DPC, and so that was a super easy way to kind of link in, and people were seeing it all over the place, you know, different people, and people can then send it to their friend, and that, it just, even if you hate Facebook, I recommend doing it. The other thing that has been really helpful for me, if you can, most people will say probably print advertising is not, it's pretty expensive, and it really doesn't necessarily draw in people. But if you can get an article written about you, or a TV station do a story or a radio story, and of course you say, well, great, like, how do I do that unless I know someone? One thing that I did that worked was I emailed a reporter who had written an article about health insurance and told her, I enjoyed your article, I'm not sure, and then just blah, blah, blah about direct primary care. And I didn't really talk up myself too much. I just said there's several of us in the area doing this. It's really beneficial for people who can't afford insurance or who have a high deductible. And she immediately emailed back, sent out a reporter and a photographer to my office. Reporters are often looking for stories to do, so that is something that kind of helped me. And then once you're out in a few different publications, other people will look to that and interview you. So that's been helpful too.
Yeah, gosh, we tried everything at the beginning. We had town halls, we went to Rotary Club, we went to all those B&I meetings, we went to so many breakfasts and things, and none of them worked. What ultimately worked really the best is all word of mouth, and I know that everyone keeps saying that, but that's really true, because people trust their friends. So if their friend says, this is a good experience, they're gonna, going to follow up on that. We have had a couple articles as well, and one piece in the news, and so that's gotten some people just kind of cold. And then Facebook too. I found don't waste your time writing like really thoughtful, health-based things. Nobody cares about sunscreen or whatever. But if you take a picture of the flowers that you gave your nurse for her birthday, that will go viral. Or your nurse that just got engaged. People really like that stuff. So they like the human interest stuff. And then besides that, I had a patient who sent me a picture or scanned in a copy of her ER bill that she had, you can imagine, while she was out of town on vacation. And anyway, it was a whole debacle. And so that was great. So then I just took that bill and then I tallied up what all those things that they did in the ER, what it would have cost us to do in clinic. And that got, thousands of views and many shares too. So those kind of shocking, people know this stuff, but shocking, surprising kind of stuff is what kind of moves. So go for that.
Okay. Kylie, while you have the microphone, folks want to know about practice size. And I know this is one of those snowflake kind of questions. Everyone's different and different objectives, different goals. But how did you decide, or did you decide this is my target panel size for my practice? How did you do that?
Yeah, that's a great question. So that's one of the questions I asked all the, everyone that was doing DPC before me, kind of. And 600, you hear 600 is a panel size, quite a lot. So I thought, okay, sure, I'll do that. I am at 500 now, and I'm still accepting patients, but I've slowed it down quite a lot. We have two other partners. One of the guys is newer, and I want his practice to grow. And 500 feels really nice. Some of my other colleagues, female colleagues, also advised that they thought 600, and now they're at 600, and they wish they'd stopped at 500. But I think a lot of it depends on your mix. So, I'm family medicine, so I have all ages. We have a few newborns that trickle in here and there, which is always fun. And they take a lot more time at the beginning, and then our older folks take a lot more time in general. So it just depends. Right now, I feel like my mix is pretty steady. But I think the way I judge that is how I feel at the end of the day, or at least at the end of the week. I guess I can't always judge it day by day. But by the end of the week, did I feel worn out? Then I need to stop. If I felt like I had a lot of extra time, which is not a terrible thing, but if I had a lot of extra time, then maybe I take on a few more families. But that's how I judge it.
Okay. How long did it take you to break even?
Oh, I wish I knew. No, it depends on what you mean by break even. 6 months, I think, would be a good.
Okay.
Yeah.
Okay.
6 months for me too.
Yeah. And what about panel size? Mara, you want to address that?
So I'm at about 200 right now. Again, I have a micro practice, so no staff. And I'm still, so I initiated a wait list last December, and I am still moving people off of it. And the other thing that we don't always talk about a lot in DPC is people will leave. I mean, we're wonderful, but patients move, and sometimes they don't feel like they're using the services. So the wait list has been really great because it's let go of that sort of financial anxiety associated with patients leaving. So, I have 3 people this month who are moving. So that's fine. I'm able to move some people off the wait list into the practice. And so one thing that has been really nice it wasn't like I planned all this out, but I would advise people to kind of set a minimum goal for yourself and just start a wait list at that point. Because the other thing the wait list does is set this kind of cachet to the practice, like, oh, there's a wait list, this must be a really good doctor, and it's like people want it even more because they can't have it right away, and then it just allows that, again, just the anxiety associated with maybe my practice is my numbers are gonna start to decline, and what if everyone leaves? You just sort of pull people off of it, and it's been a really nice balance. So I think, I can envision I could probably easily care for 250 with my current setup. But like Kylie, I just kind of adjust based on how I'm feeling. Am I able to kind of keep up with everything and feel like I'm able to do everything else in my life that I want to be doing reasonably well? And so add patients in as I can.
I was just going to mention too, I totally agree about the wait list. Last December, it was busy, right? It was flu season, and I went on vacation and whatever, so I started a wait list then, and yeah, I got really popular. and now everyone's off the wait list again, which is fine. But it's nice to be able to do it that way too.
Okay. Corey, you want to address that?
Yes, my original plan for my cap was 600 patients. I'm at 425 right now. And I would have liked to have been, I thought that I wanted to be at 600, and at one point I tried to be disappointed about that. But it turns out that when you're slogging your way through the beginning of DPC and trying, trying all your different pathways, that sometimes you find out that the systems you've set up for yourself aren't as helpful. They don't streamline things, they actually get in your way after a certain number. So I was really happy that we actually were able to, I broke even at, I set a goal to break even by 200 patients. I broke even at about 175. And I have a full-time staff member, my patient care coordinator, and that I would break even at 200. I would make what I made in my old practice at 400, and that I would be, I would be padding my retirement account at 600. Mm-hmm. So I'm at 425. So I'm not losing money, and I'm also padding my retirement account. But I'm actually happy that I'm in a place where I can actually choose to slow down or speed up, so that we can refine the systems in the office and be much more streamlined and still keep the one doctor, one staff ratio.
I think Dr. Vanneman made a very good point that I've experienced also, and that is, I wasn't sure if it was it going to be 300, was it going to be 400, and it took me to sort of get there to see what it felt like, because it matters a great deal, the mix and the complexity and the age of your patients. So when you're there, I think you know it. Sometimes you know it a little too late, but you made a very good point.
I was just going to say the pace also matters. So, because initially, there's a lot of work to do when you're getting new patients on. So when you're getting, several new patients in a few-day period, that can suddenly feel like a lot. But then once that kind of settles down, you're like, oh, everyone's kind of tucked in. We're going around, and we can go a little bit more. So yeah, you just have to feel it out.
So question for Dr. McLaughlin, and did you have a particular mentor or when you were doing the micro practice? Because that's a little different than some folks in the room. Did you have someone that you turned to for that?
So I discussed my hatred of Facebook earlier, but there is a Facebook DPC docs group, which is secret, so you have to friend someone who's in it and they'll add you. But that was a huge source of information. There's one other doctor locally who was practicing that I was an acquaintance of, and she was a great help. I asked tons of questions in that group. The AFP has a member interest group that for DPC, which I would encourage joining if you're not already on there. So I sort of sought out and paid attention to people who were doing a practice like mine. And copied like the answering service I got from Robin Dickinson. I don't know if she's here. She's in Colorado, I think. I've never met her, but she's the one who she has a solo practice and she had used it and it seemed to work well. So I think just talking to as many people and getting as many different ideas, and then sort of you'll find people whose kind of interests or practice style aligns with what you are envisioning for yourself, and sort of talk to them, find out what they're doing.
Okay. And while you have the microphone, someone wants to know, what about, and this has been addressed already to some extent, but what about vacations? How do you handle vacations? And we'll go across the panel with that.
Yeah, so for financial reasons, when I first made the switch, we took only one vacation that year. That was like the most painful part about the transition, I think, because I love traveling, but we just decided, okay, we'll just do our beach vacation that we usually do with the kids. And then since then, what I've done, there are now 3 at least of us very locally who are doing DPC, so we will cover for each other. Typically, we'll still be available by phone unless I'm in a location that doesn't have phone coverage. So most of the time, I'll still kind of cover phone and computer and that sort of thing, but then someone's available to see my patients in the office if they need to get seen. And typically, it's been like 1 or 2 patients maybe that week, the week that I'm out. And my goal is to be totally off the grid with somebody else covering everything by next year. That's been, honestly, mostly in my own mind. Like, it's hard for me to let it go. I feel like it's my baby and I'm like leaving it. But I know that's mostly in my own mind, so hopefully by next year I'll just totally leave for the week.
Okay. Kylie, how about you?
Yeah, so starting out at the beginning, my partner, like I mentioned, is internal medicine, so children really scare him. So whenever I left town, I'd always call another family doc friend or a pediatrician friend who was doing this kind of model, and they would, be on backup call for kid stuff. And that worked fine because DPC docs are really nice. And now I'm fortunate enough that there's 3 of us in the practice, and our third doc that we brought on is another family doc. So, he's comfortable with, pregnant people and kids and stuff like that. So, so when we're away, we kind of have we basically just forward our after hours phone to whoever is covering for us in our practice. And then everything else gets an automatic reply. So my text just says, hey, I'm gone, call if you need something. And same thing with email, says, hey, I'm gone, and I'll email you later, or call the clinic. So it's nice when and patients are good, I think, especially if they have a little warning. I try to give them a little warning so that we can do whatever stuff needs tidied up before I leave town.
Okay. Corey, you want to talk about vacations? And you said you have a pediatric group.
Yeah, I have my med-peds group. The smartest thing I did was not trash my relationship with them when I left. As a matter of fact, I'm still waiting for them to join me. They do the backup, but my patient care coordinator, Jody, always is constantly monitoring our phone calls and our texting to see whether or not people can wait until I come back, or do they actually really need to see a doctor. And she just triages all of this stuff and passes it on. And, I will tell her every morning, when do I expect to be available again? And those things that she thinks I need to handle, she will triage towards me. And those things that need more immediate response, she will farm out to one of my folks. So I have backup with this masterful triage in the middle. And then when she goes on vacation, I make a lousy Jody, but so we don't do physicals and we don't do anything that requires a lot of her interaction whenever she's gone. But then I get to manage the whole practice, and I think she arranges her vacations so that I will appreciate her and give her a raise.
One of the questions submitted has to do with pricing, and we don't want to talk about specific prices. But do you have different tiers in your practice? Do you have a different price, monthly price for children? How does that work, Corey, with you? And we'll go across the panel.
Yeah, probably the most innovative pricing structure I've ever seen. I'm not using it, but it's the doctor who charges $1 per year of age, so per month. So if you're a year old, it's $1, and it goes up to $99. And if you live to be 100, it goes back to $1. And it's like, I really wish I'd heard of that. But I have a monthly price for adults and another monthly price for children. And if I do reward people with a 10% discount if they go ahead and pay annually at the time that they sign up, and if they have a family of 4 or more, there's another discount on top of that. And then a small amount for each additional child past that. And I said something earlier about what my monthly fee was. That was ancient history. I wasn't, so if the Federal Trade Commission is listening.
That's right. So no specific prices, generalities. So.
I have, as of now, 3 different basic tiers, up to 0 to 18, 18 to 49, and then 50 and up. And I give more or less half price for children up to 22 who are enrolled with a parent or guardian.
Yeah, so we have basic tiers too. We go 0 to 17, and then 18 to 39, 40 to 59, and then 60 and over. And then our 100-year-olds get that special deal as well.
Okay. And what about couples, and what about families? You have special pricing for those?
We didn't want to be responsible for defining what a family was, so our kids' prices are super cheap. So that is basically our family pricing.
That's your family price.
And I do just basically half price for kids. They can be enrolled with any parent or guardian.
Okay. And how about you, Corey?
Similarly, at one point we did allow kids to enroll on their own, and it was more if they enrolled on their own. But I found it really difficult. It's challenging in a way that's hard to describe. Now, if I was doing pure pediatrics, I wouldn't be able to do this. But one of the things that's really beautiful is about being able to take care of parents and kids. I take much better care of kids when I can also take care of their parents. Right. So we now make it mandatory that that at least one parent or guardian sign up.
Okay. We have about a little more than 5 minutes. So here's a very important question, and it's sort of the reverse of marketing and growth. It's sort of that be well kind of question. Do you ever have to fire a patient? How do you do that? Why? What's been your experience with parting ways with someone? Corey, you want to address that while you have the microphone?
Yes. I don't think I've had to fire anyone yet. I have been able to guide people to other places for their benefit. Again, there's something to be said about the respect, and the issue of respect. And I've had very few people come in, get all their services done, and then take off and not pay me. I can count on less than one hand the number of times that's happened. But I'm very clear with people beforehand that it says on my website, I don't do chronic pain management, meaning, don't look to me for your narcotics. Now, that doesn't mean I don't have patients that aren't on chronic pain management, but those are mostly folks that I had already knew, or who've come to me with a clear transfer of care from another physician. And I'm very clear about what the rules are if we're going to keep doing that. So I just don't get an army of drug seekers. Okay. And I do I do the free first visit, because the heavy lift, there's such a heavy, a big learning curve for patients about what the style is. So I let people come in for free the first time to talk to me. I don't do any medical advice at that point. I just let them ask questions, and we kind of, take each other's measure. And the folks who are looking for something from me that I'm not ready to give, they just don't sign up. Fortunately, almost everybody who actually comes through the door ultimately signs up.
So that's been one of the concerns, I think, is in a new practice. The patient comes in they get their physical, they get the labs they've not had in 10 years, they get an EKG, and then they're gone. So your experience, that doesn't happen very often at all. Okay. All right. Mara?
So to answer that hasn't happened to me either. I purposely didn't set any time commitment. When patients sign up, it's month to month, so they could theoretically, basically pay me twice and leave. And that has not been an issue. I think most people, if they're going to be dedicated enough to get in there and start it, now they may not stay a full year, they may stay less than I would ideally like them to stay, but most of the time, I haven't had the experience of them coming once and then dropping it. And then to answer the question about patient-physician fit, should we say, I think having good boundaries and being clear about those with the patients is extremely important. And I'm really happy we're going to have a talk about that, because I think that's something that we as a DPC community need to be kind of talking to each other about. And I also try to talk to my patients either in person or on the phone before they join the practice. And there have been times when it's very pleasant interaction, but we just both agree this is not the right fit. And so I think that can be helpful to get that, sorted out before they're there for the first visit. And then sometimes there's things where maybe it's usually more of sort of a behavioral sort of thing versus anything else, where I just need to be clear that these are appropriate things to call about. This is not something that I can do in this practice. This is something I can do, and being clear about that, and the patient will either kind of be able to go along with that or not.
So our approach to enrollment and things has evolved a lot over the last 3 years. At the beginning, we're happy to take whoever wants to pay us cash and walk through the door. And then later, we've gotten to be a little pickier, which is nice. So currently, we actually require all potential members to have a meet and greet, either by phone or in person, just to kind of avoid any of those bad fits. If someone, does become a member and they're not happy with something, they basically self-select, I think. I I can only think of one person that I sort of wrote I'm so sorry we are unable to meet your needs. I will be happy to provide 30 days of whatever as you find another provider. So I guess that was my only firing, you know, when someone's rude to your nurse a couple of times, that's enough for me.
Okay.
What was the other part of this question? Dun, 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 dun.
Dismissal of patients.
Yeah.
And,
I was just going to say, as far as like letting people go, usually it's because either they move or because they're having trouble paying their bills. But I've never fired someone because they couldn't pay their bills if they stayed in touch with us. We have people that are artists or have all sorts of, you know, their income is not always consistent. And as long as they're nice and they stay in touch with us, we will help them. So no one's ever been fired. And even people that I've offered free care, sometimes they just disappear. So, you know, we do what we can.
Okay. All right. So I'm going to give each of the panelists 30 seconds to share with the audience what's one thing that you want folks to take home that you've learned from your practice of direct primary care. What's one thing you've learned? What do you want to share and they remember this one pearl, this one tip? Corey, you ready?
Oh, God. Okay.
30 seconds.
Yeah, no pressure.
Yeah, no pressure.
I've been waiting the whole moment to the whole hour and a half to say this, but I need for everyone in this room to understand the most miraculous thing that happened to me when I became a DPC physician, and it happened when people started re-enrolling, is that I realized that I was value hiding in plain sight. You are value to your patients, to yourself, to your families, to your communities. And we have been in an abusive relationship for so long. We've had our finances controlled, we've been isolated from each other, and we have had our confidence undermined for so long that sometimes we don't realize that we are the value that our patients are seeking. Seize it, use it, go forward with it. It will save your life, and it will certainly save your career.
Excellent.
I agree with all of that. And then, let's see, I will add, you can really make this practice whatever you want it to be, as long as it is offering a value to enough patients in your community. And so I think sometimes we get excited, like I'm super excited about micropractice because that's what I'm doing. You know, we all get excited about like the way that we're doing DPC, but find the people that are doing what you want to do and talk to them, because you can really make this work in a way that's a way that works for you and your family. And I would also make a plug for just keeping your overhead as low as you can. A lot of us just like love talking about all the great deals we get, and it's kind of like a game in some ways, but keeping your overhead low will just help relieve that stress. It'll mean you need to see, you know, less patients to meet that break-even number. And so we're all happy to kind of share ideas about that.
I'll keep it really short. I just want to say all of the practices that I've seen fail that I can think of had marble countertops. So maybe don't do that. Kind of, you know, keeping your overhead low, all you need is a stethoscope in a room and some time, really, is all you need to do this. And the last thing is just, especially if you have little kids or even if you don't, you know, life's too short to be miserable, so be brave.
Thank you all for attending. I know you will agree with me. This has been excellent. Let's thank our panelists one more time. Thank you.